Hello and welcome to MedCity's Invest Digital Health Conference. My name is Orundhati Parmar and I'm the editor-in-chief of MedCity News. During the pandemic, I had the opportunity to interview a cardiologist from Mass General, and she spoke of how patients were so afraid to come to the hospital during the pandemic that some of them unfortunately passed away. She also mentioned that had there been some good remote patient monitoring programs that they were part of, then this could have been avoided because she could have intervened when she saw something different in their measurements and have them come to the hospital. So we all know the importance of remote patient monitoring, but of course, like everything in healthcare, it's all about dollars and cents and what gets covered. And that is very much the conversation today. And to have some answers about where the world of reimbursement is and where it needs to go, I'm very pleased to introduce our knowledgeable panel. We have Jay Sultan from LexisNexis Risk Solutions, Tanvi Abhi from Vida Health, Aurélie Delaforge from Cardiologs, Julie Viola from Philips. Jay is a national thought leader in healthcare, advising over 200 payer and 50 provider organizations on new payment models, clinical data use, and interoperability. Jay currently leads healthcare strategy at LexisNexis, managing the team that sets forth strategy and leadership for the company's healthcare solutions. In his previous role at Cognizant, Jay designed and helped drive the COTS products, as well as custom development to support interoperability for payers. Previously, he was the Chief Product Portfolio Officer for TriZetto, later acquired by Cognizant. Welcome to you, Jay. Tanvi is the co-founder of Vida Health, a digital health company that empowers patients with chronic illness through personalized tools for disease management and remote patient monitoring. Vida Health was founded with a mission to deliver greater transparency in healthcare. The platform equips patients on their healthcare journeys beyond the four walls of traditional healthcare facilities, giving them personalized guidance and simultaneously enabling clinicians to deliver more timely and effective care to improve health outcomes. Welcome, Tanvi. Aurélie leads Cardiologs activities in the field of RPM. In particular, she currently oversees the development and commercialization of the Cardiologs RPM platform for smartwatch ECG in the US. Prior to joining Cardiologs, Aurélie was a manager at Bionest, a healthcare-focused strategy consulting firm. With tenure both in Paris and New York, she was the firm's expert in the field of diagnosis and precision medicine. Welcome to you. For Julie Viola, improving health outcomes is not an idle phrase. It has been a driving force in both her professional and academic life for well over a decade. That's exactly why she earned her master's degree in health administration from George Washington University in 2017. Her academic focus on population health in obesogenic environments stemmed from her earnest conviction that better health can come from healthier environments. At Philips, Julie is deeply committed to the company's bold vision to improve the lives of billions of people. Virtual care and digital health care are critical components of that vision, and something that is a driving force behind the healthcare innovation Julie and her many colleagues bring to health systems around the globe. Outside of Philips, Julie is an adjunct professor at American University within their graduate studies focused on health policy and payment models. Now, I wanted to turn it over to Jay for a great conversation. Please feel free to set questions in the chat. Jay will weave them in as he feels appropriate. Go ahead, Jay.
Thank you so much. And thank you for this opportunity to be here with all of you today. We're going to work under the assumption that no one here needs to be convinced that remote patient monitoring is a good idea, what it is, when would you use it, that kind of thing. We're really going to focus narrowly on the question about reimbursement or payment. How is today and how will in the future the healthcare system in the US, and we'll actually talk a little bit about outside the US, reimbursing and funding the use of remote patient monitoring, and what is that link between current and future funding methods and the ability of the industry to accelerate its valuable use and adoption of RCM, as opposed to maybe some unvaluable uses and adoptions of RCM. So we have our panel with us, and I'm going to ask each of them a question. I do want to encourage everybody who's listening to this live to use the chat feature. I'll be monitoring the chat, and we want to make this panel session as interactive as possible and really bring things forward. As we start the conversation and we think about the way reimbursement here is in the United States, as somebody who's been a talking head on the topic of value-based care or payment reform or value-based reimbursement, I would tell you that the US is very much a fee-for-service world. And we have really not made the transition to meaningful value-based care, which I would define as a provider having such a financial risk and financial and health outcomes that it changes the way the provider would treat care as opposed to the way they would treat under a volume-based approach. So there's pockets, there's places that we all are aware of where those value-based care programs are actually effectively running. But for the most part, two types of entities pay for a lot of the remote monitoring work today. The first are payers, and payers have a vested interest, of course, in reducing expense and improving the quality and access to the point that was just raised for care. They also have to worry about churn. If you're a commercial payer, last report I saw said on average you keep a member for about 2 years, and it can be less than that depending on what type of insurance you have. So it doesn't really do a lot of good to invest today in things that will make somebody healthier 5 years from now because somebody else is going to reap the benefit of that. So payers are very focused on ways that they can do payment, especially innovative payment, that help reduce the medical spend and help improve the quality and the efficacy of the care in the term during which they have that patient member as a customer. So payers, including the federal government through CMS, are obviously one category of people who pay today. The other is certain providers. There are provider organizations, hospital systems, that are funding and developing and investing in RCM, remote patient monitoring. For some, they're doing it because they are under value-based care. They do have significant risk, and they want to manage their risk by, again, the wise and appropriate use of RPM. Others I see doing it not for financial reasons, for kind of more mission-oriented reasons. They think it's the right thing to do. It's a skill they want to learn because they think it's going to be more important in the future. The challenge with that latter set is that typically those type of investments don't prove to be long-term, meaning that at some point there has to be a financial model as to why organizations, a provider organization, would continue to fund remote patient monitoring. It has to be because it saves them expenses, it helps increase their revenue, it brings out better outcomes that, again, in some way they're rewarded for. If for them to continue it in the long term. So I'm going to turn now to our panelists, and I'm going to begin just in a random order, the order they are on my thumbnails here with Julie. Julie, I want to ask you specifically about some of the digital tools. Digital tools are gaining a lot of traction. What is Philips doing as a company to ensure access to these digital tools, especially when you think through it the lens of things like health equity and who has access to the equipment or the tools or the Wi-Fi or internet access they might need in order to be able to use these tools?
Yeah, thanks, Jay, and thanks to everyone else who's making the time to join us today. I think a lot of us have seen the statistic of 76% of people here in the United States over the age of 50 want to remain home for care, but only 42% of them over the age of 65 actually have the access to make that happen with broadband. And so one of the things that Philips has started to do is, you can wait till things are perfect, or you can get out of the gate and try some things. So one example is what we've done in partnership with the Veterans Affairs organization through Project Atlas. We've, through discussions with them around equity for veterans care, we looked at different areas of the country where veterans could not get access to care easily. So for example, if you think about northern Montana, getting to a VA facility for a number of veterans was over 2 hours. And if you think about a round trip for an appointment, it could be upwards of 4 hours. And that doesn't even take into account the weather that they have in the wintertime. And they have to do a lot of this because there wasn't access to broadband. And so what we looked at was, well, what if we put a pod in an American Legion? We know that that's where a number of veterans were going for not only social interactions, but where they wanted to meet each other. And so what if we could give them access to a doctor in a pod through a screen with wearables intact? So if you couldn't have access to those types of tools at home, then let's put it where you are. And I think there's two things of value there. Number one, you're giving access where there hasn't historically been access. And number two, you're providing an experience for a veteran in a way that they've never had before. So if you were to, Google Atlas with Philips and the VA, you'll notice that a veteran would enter into an experience, into a pod. It's wheelchair accessible. There's room for a service dog. And so we really took into account a lot of the user experience, not just the provider experience. And then there could be things like RPM tools that are embedded into that pod, and telehealth visits could be enabled. So those are some of the things that we're starting to look at. I think the other secondary piece of this is what you mentioned. There's a need for broadband and access, and so partnership. And I think that's something that myself and the other panelists are going to talk about, is that I think very few companies and entities, payers, providers alike, are going to be able to do this alone. And it's going to take not only reimbursement shifts, but really a change in attitudes in terms of how we go to market, not just in the United States, but across the globe.
I think that's right. That's really good. So let me turn now to Tanvi. You've worked with a lot of different workflow models. What are some of the workflow models that you think make remote patient monitoring successful?
Thank you, Jay, and thank you to my fellow panelists and everybody who's attending. We take a little bit of a different approach at Veda Health to remote patient monitoring. When we first started on this journey, we took the mindset really that technology could be a panacea and really solve the challenges that we're facing today. And over the years, we've really come to learn that there are so many important pieces to the equation that technology alone doesn't solve. I remember in some of our early deployments, particularly looking at 30-day readmission risk for patients suffering from congestive heart failure, the feedback that we got was really astounding. Patients felt better cared for. They felt like they were being looked after. We actually published an IRB study around this, where we were able to reduce readmissions by 75% between the investigational and control group. But one of the key takeaways for us was there's actually still more to this that's missing. We were at the time, this was 5 years ago, using Bluetooth-enabled devices, and there's a real access issue with that. So one of the things that we think about from a workflow perspective is on the patient side. How do we enable better patient workflows through SMS interaction, voice interaction, app interaction for those who have smartphone that they know the password to their iTunes or Google Play account and can actually download an app, and being able to meet patients in the workflow where they're most comfortable. And then the other workflow piece is, of course, on the clinician side. We really believe that technology can enable better health outcomes, like everybody here, but it is not the only piece of the puzzle. And so what we've done at Veda Health is actually stand up clinical teams to support in the adoption of remote patient monitoring technologies. And we really view this as an ecosystem that is encompassing of digital care pathways, devices, as well as clinical services in order to enable both that patient and clinician workflow.
That's great. That's great. I want to ask a couple questions about what some of that workflow is and stratification and stuff in a minute. But before we do that, I want to bring in our last panelist. So Aurelie, I'd love to hear a little bit about some of the reimbursement challenges that you've been getting feedback from with the conversations you've had with cardiologists, for example. When you ramp up, when they're ramping up the remote patient monitoring, what are some of those reimbursement challenges those specialists talk about? And what are the areas that you've heard about that are probably most needing improvement?
Sure, absolutely. No, thank you for that question. So I mean, the most important thing is that very clearly cardiologists and physicians are, very excited about remote patient monitoring and the way it can really revolutionize the way they approach, patient care pathways. But when you talk to them, it's really striking to see how they do it like pro bono and therefore on a limited scale as of today. So RPM reimbursement for them, it's absolutely critical for their adoption at scale. So they keep on mentioning it, during calls at HRS, in major conferences, basically, as a major unmet need for them to truly adopt RPM programs at scale, despite the existence of the codes. So there were a couple of issues that came back up. The first one is that there is a lack of awareness around the newest CMS CPT codes around RPM. A lot of people actually don't know them and don't know what they are about. Mm-hmm. But for the other people that actually know them, there is a lot of frustration around it. And we've heard physicians say that it's very hard to bill for RPM, or that you're never going to be able to make money off of RPM services, because there is either too little money associated with those codes, and as they grow those operations in the RPM world, they're going to be inundated with data, so they're probably going to need to hire some more people to deal with that. Even if they use like AI tools like ours at Cardiologs, it's still going to be a lot of work. And so they feel like the reimbursement money that they're getting is not enough for them to scale their operations. But the other issue, and perhaps that's the one that is a bit more concerning to them, is that they feel like a lot of their claims are rejected. For them, it feels like payers have a ton of reason to reject RPM claims that they're submitting. So for them, it's a lot of efforts without guaranteed rewards, basically. So some of the reasons that seem to appear where there is like a gray zone, it's not very clear, there's a lack of clarity from the payer side on, what is required to make a successful bill, is like, as of today, 2 healthcare providers cannot bill for RPM codes for the same patient at the same time. But there would be like clinical indications for which that would make sense, if a patient is followed by an endocrinologist and then a cardiologist for 2 separate reasons. They might benefit both from RPM, but they can't get reimbursed both. Same from the data point requirements, like you need 16 data points per month to be able to bill a certain code. But for some indication, that sort of doesn't make sense. For arrhythmia screening, typically you have to be, usually the clinician are going to tell you that you have to record when you're symptomatic, which may not happen 16 times a month. So all in all, with that, there is frustration that has been building up for clinicians on how to handle that uncertainty.
So let's stick on that for a moment, and let's stay with U.S.-based reimbursement, and let's talk about, we can think of payers in 2 worlds. Most providers think this way. For those of you not in the U.S., there's CMS reimbursement specific to traditional Medicare, and it sometimes creates regulations and mandates on privatized or Medicare or Medicare Advantage. And then there's kind of everything else, and everything else is commercial insurance, managed Medicaid, sometimes state-based Medicaid, et cetera. When we look, there was a famous correction that happened early in 2021 because CMS acknowledged that the way they put the coding in place wasn't sufficient. It wasn't anything that would work for providers. So since that correction made earlier this year, if that's the only change we see, and there's no further changes made to the way CMS reimburses for remote monitoring, do we think the current reimbursement methods, i.e. the codes you're allowed to use, as well as the rates, the amount you get paid for that, is that sufficient for organizations to begin to adopt and use RPM? Ask any of the panelists that has a point of view on that. And maybe, Aurélie, invite you to start by saying, you said that the doctors you've spoken to say that the reimbursement is not sufficient enough. Is it just that they need to be paid more? Is it that they need the ability to use RPM on a broader population? Do they need to find ways of reducing their expenses? Is there more about how reimbursement might change from the monitoring versus the intervention related to RPM? Talk a little bit about kind of how we change.
Sure, no, absolutely. So I think overall, the perception is that it is a great start. It was great to see RPM services starting to get reimbursed, or especially with COVID, there were exemptions that existed, and the rules are a little bit more loose. So that really helps. So I think physicians are happy to see that there's a start of that. But the shortcomings is really even though CMS answered a lot of questions in 2021 through what you just mentioned, there's still a lot of gray zone and lack of clarity for some of those codes and some of the requirements that need to be met for that. So I mentioned, the 16 data points, for example, requirements, which again, could be refined according to the indication that the patient are under, or the fact that, again, 2 HCPs cannot bill at the same time. So they clarified a lot of things already, CMS, with in 2021, but it's still very much a learning process for everybody, I think, for CMS, for the physicians, and for the industry as well.
So it's not just the codes, it's not just reimbursement rate, it's also the clarity and the clarification of when and how you're allowed to use things.
Exactly. And everybody's learning. So we'll see where things are, in 2022, and if more clarity will come. And I'm pretty sure that the rules will be revised eventually to meet what has actually happened in practice in the past couple of years.
Very good. Julie, Twanvi, do y'all want to add anything to this part of the discussion?
Yeah, I think there's some exciting things happening as it relates to the reimbursement, specifically to CMS. And I think there's a couple of different lenses you have to put it under. Number one, under the public health emergency, we saw, I think it was 110 to up to 270 services, now being reimbursed. I think to Arlie, there's definitely some of those finer details around folks who have comorbidities that have to be worked out, so we can ensure that there's an incentive for the providers to be able to do that. I think the second thing that comes to mind in terms of the lens we're looking at this under is that when we talk to health systems that are maybe a bit more lagging or hesitant, they really need help with some of these more complex patients. And so while they might be confident in things like cardiovascular, because we see outcomes and we have so many data points and we know that these things work, and they're trying to move forward with things like cellulitis and some other initiatives. I think where they want the help is when we start getting into the RTM, so therapy monitoring, and I'm bullish on what we're seeing for 2022 around that. But I also think what you mentioned earlier, Jay, about who's going to benefit, who's going to hesitate, who's going after this, it's really going to depend on what type of a health system is engaged, what type of a payer population they have. So if you think about a Medicare Advantage, for example, where they're trying to earn as many hit the 5 stars and hit the star rating, they're going to be more sensitive versus a commercial pay, et cetera. And so something that is of interest to me and the rest of my colleagues is when you think about the metrics that we're going to market with and that we're collaborating with payers on, is not just the outcomes. If you think about something like a readmission program, that's of course important. You have to measure readmissions. But if you think about it under the lens of Medicaid and Medicare, especially like I mentioned, Medicare Advantage, that experience during that 30 days is really important. So what does the 30 days look like from when they were discharged to, that magical day 30? What's happening? How is a physician or a nurse or a social worker or a community paramedic interacting with that patient at home? Do they feel safe? Do they feel like somebody's looking over them? What type of indicators are in the home that we can predict that there's something not right? I've heard of security companies looking at how often the refrigerator is open, movement through the house, right? So all these things are in the right direction. But I think what we have to really understand from a health system standpoint is if they just did a huge new construction project and they're trying to get people in, there's going to be a different incentive versus those that are having overflooded emergency departments and a different payer mix. So I think it's complex. It's not a one answer, and all of these things have to be considered. And I think I saw a question come in around that experience, and I think that goes into the leading versus lagging indicators or outcomes metrics versus process metrics. And I think those are the types of details we have to start digging into.
That's great. That's great. I want to come back to one thing you said, but first I want to give Twanvi a chance to weigh in if she had anything she wanted to add here.
No, yeah, I agree with Julie and Orly. I think we're certainly in the early days, and RPM in many ways, it's still in a nascent place. this CPT reimbursement for 99454, 457. These are the codes for those who aren't aware in the US where physicians can actually be reimbursed. They're fairly new. We've seen these for the last 18 months. And I think with anything, this is part of the learning curve of how do we then take this as a basis and continue to build on it. Incident to billing, for example, is something that's new. So whereas physicians had to provide these services directly from their offices in the past, they can actually work with companies like any of ours in delivering on this now. And I think we're going to continue to see these types of micro innovations over time. I think we're going to see more therapy specific. And I think we're going to see, more, what we term within our organization, proxy clinical outcomes that are being measured. So yes, readmissions are important, but how long does it take for a patient with hypertension to get on the right medication for blood pressure control? Is it 3 weeks, or can we reduce that down to 1? Is it 6 months? And so these are the types of things that we're going to continuously be evaluating, and I think ultimately will inform how CMS continues to iterate on this. And we saw a similar journey in telehealth, and the pandemic
Right.
has flipped that completely on its head. And I think we're starting to see that happen in the remote patient monitoring space as well.
And I think that's a really good point that you're making. Having been around healthcare transformation a lot of years, these things are always like this when it starts, right? First, there's no reimbursement at all, and everybody cries and yells and screams. And then we try to reimburse, and we don't have the definitions of the codes right. Nobody knows, and there's an education process. And all of this is, you go at the example of telehealth. I can think of any number of other examples of innovations around transportation or any number of other things where we've had the same kind of issues here. So, there's existing infrastructure. If my friends at Weedy are listening, I think they've done a great job in the past with analogous examples of driving that education about coding and definitions and stuff forward. So I do think, simply put, as long as the reimbursement is significant enough to attract people into the space, whether that's a CMS or private or, again, provider-led kind of reimbursement, that the use of the codes and the refinement of the codes will come up. And then we'll also start to see the counter effect where organizations, especially private payers, are going to recognize the abuses or the misuses of coding that's available, and they'll start to put in restrictions and and various other things. So this is all part of the maturation, really, of it as an industry. But something that the two of you said really wants me to move on to another question. We will get to the questions that are in the chat box, but I do want to go here. One of the things about RPM, in my mind, is that it creates value in lots of ways, some of which we don't remotely monetize. We always call healthcare payments reimbursement, as if the doctor spent money and we're going to reimburse the money the doctor spent. There's all kinds of other forms of value that get created. For example, if I have a patient who the choice is to discharge them to home with RPM or to discharge them to a SNF, it's obviously going to be far more cost effective and probably better outcomes for the patient, all things being equal, to discharge them to home. Well, there's no value accretion that happens to the RPM organization that's related to the saved money from avoiding the SNF stay. Same thing, one of you brought up medication adherence and how can RPM help with, the most important thing with a newly diagnosed diabetic is getting them onto insulin and checking and stuff. And what's the role of RPM in accomplishing that and preventing ketoacidosis episodes and stuff? So my question to all three of you is this: where do you see areas where there's value that RPM creates that the current coding system doesn't address? What else needs to be changed in the reimbursement system to capture some of these other areas and what are those areas of value that RPM creates?
I'm happy to kick off on this one. Just briefly. To touch on some of the earlier points you just made, Jay, what we're seeing in terms of interest from the industry is just a very important intersection of folks who have one foot in fee for service as well as one foot in value based. What we find on the pure fee for service world is that the codes are not quite sufficient yet. Folks can break even. You definitely have, as you pointed out earlier, the altruistic approach of, well, this is just good for our patients, and as long as we're not losing money, it's good enough for us. But where we're seeing really kind of that greatest market acceptance is with folks who are saying, we believe that remote care in its various shapes and forms is going to be the future of how we deliver healthcare in conjunction with in-person care, whether that's telehealth, whether that's remote patient monitoring. And we view this as a way to more effectively triage patients to the right setting. And so where we are with this ultimately is enabling folks who are in the fee-for-service model to experiment, to try and to implement these programs while continuously looking at those outcome metrics. And I think the biggest gap that we're seeing just purely from a structural standpoint is there is really no connection right now between the reimbursement for fee-for-service codes and the outcome metrics. And I think at some point, we'd love to see those things better tied together where, potentially there's reimbursement for the devices. And yes, we talk about reimbursement in the ways that you mentioned, because it is physician time or staff time. They are in some way, shape, or form buying the devices. And I did see a question on that in the chat, buying the devices from companies like us, Philips, and others, and ultimately have to make up that cost. And so, the way that we're looking at it is really how do we take that fee-for-service model, and within that model, really start to generate some of these clinical outcomes that can show value beyond it and beyond, your kind of top clinical metrics like readmissions.
Yep, we'll come back to outcomes in a second, but before we do, any other comments from the other panelists?
Well, I think just to go, I love what Tanvi said earlier about medication adherence. I think there's just a lot of different components to this. And I think looking at the patient in a more holistic way and reimbursing it as such is great. I mentioned RTM earlier, and I think it's important to go back to it again, because, I think, again, thinking of the feedback we receive from health systems, and I saw the question around value-based care and those that are encouraged to use that. If I think about patients that are harder to reach, harder to engage with, that really you don't want into a hospital, a lot of the respiratory type of patients come into play. If I think about folks that are struggling with MSK diseases, transportation to a health system or going to see a provider is difficult. And so RPM or RTM are all tools that can really help. And then again, you're getting back into more of the patient experience, but also the caregiver experience. I think, many of us, myself included, have older parents or, complex and chronic family members or friends, and we see that experience, and it's something that we consider in our day-to-day life. So when I look at what the RTM changes in reimbursement are doing, where you're really starting to get into that change of not just the physiological data, but the full view of the patient, more of the questionnaire type of information, and then also the way that they're going to providers can bill. It just opens it up, and I think again that's just a step in the right direction. And what we've started to see with RPM being the foundation for that, I think is really exciting. And then just the last piece, I know it's not as big of an issue, and I think it's well known, but just at home as the originating site. I don't want to lose sight of that because some of these things have been temporary, and just making sure that they become fully baked into the final. Sure.
Any other comments on this? Because I'd like to go back to that idea of the role of providers and value for a sec.
Yeah, I guess one last comment on this is that in terms of value that RPM can provide that currently may not be covered by the current reimbursement codes is typically, that kind of monitoring could be great to screen people, right? And as of today, there's again a gray zone or ambiguity on the codes onto whether you can use that to screen at-risk population that are not yet patients, they're not yet treated, but you could identify them so much earlier. And so that question of time to diagnosis is not something that's encompassed as a reward in using RPM and covered by the codes, but that's definitely something that's eventually RPM could, transform in the future.
Yeah, because it was inevitable in a conversation like this. We go from patient monitoring to telehealth to remote diagnostics, to remote treatment, or that there's the boundary lines here are so gray. And, I think that's actually one of the things that gives CMS and private payers pause, is that we don't know what this world is going to look like. And again, they don't want to be bound up into having to pay for things that we don't know yet what the value is. We don't know what they work. And that's where some of these boundary lines, I think, are going to be a real challenge. I do want to go back to one of the first questions that got asked to the panel, examples of value-based providers who embrace RPM. Just off the top of my head, some that I know about and I've read about or worked with. Anytime you have a list like this, it feels like Kaiser Permanente always gets top billing, but they have actually done a lot of investment, and not just in those things that CMS will reimburse, but things that the Permanente part of Kaiser Permanente is also reimbursing. So if you haven't read up on some of the things that KP is doing, you should look at that. A couple other health systems that I'll call out, because I know they've done some very interesting early work on commercial reimbursement for our patient monitoring, our Jefferson system in Philadelphia and Ascension. Both of them have launched programs and kind of gone beyond pilots in terms of their work. Are there any other where providers where the incentive for doing it is the fact that they are under risk, and so they're trying to, again, improve total cost of care? They're in a contract where outcomes matter, back to a point that one of you made before, that any of you want to call forward just to give credit to those early adopters who are out there walking the walk?
I'll be really quick, and then I'll turn it over to the other panelists. I would say that the waiver for the hospital at home, Jay mentioned earlier, discharge to home. There's also admit to home. And when we have the admit to home under hospital at home, I will say, if you look at the list of 110 plus sites and over 50 plus IDNs that have signed up for the programs, some of which Jay just mentioned, most of them that we've spoken with are utilizing RPM. And I would say that they're doing it successfully. I don't want to speak out of turn and name them individually, but I would say a great place to start is looking at that waiver list, who's applied, who's starting the programs. And then in addition to that, when you look at who they are and you look at the type of conditions that they want to start focusing on, most of them are going to start with something that's pretty, I'll say, easy to manage outside of the home, to get their feet wet, have those training wheels on, and then scale up. And so RPM is a fantastic way to do that.
Great. Anyone else want to call out some specific systems or specific models?
I think you hit it on the head, Jay, but basically any clinically integrated network, what we're seeing, and I think this is pretty true of the industry broadly, is really wide adoption of remote monitoring for value-based contracts, so 30-day readmissions in particular, but those systems now looking at how they can apply that in other pockets within their organization. So we've seen a lot of consolidation in the last few years of practices being absorbed by systems and a move to more ambulatory care models. And I think this next phase of remote patient monitoring, and I want to differentiate between the billing codes because I think it is meaningful. But this next phase that we're seeing is how do we actually adopt this more broadly than 30-day readmissions for these early adopters, so to speak.
Yeah, I think that's right. And again, it may be that some of that innovation happens with commercial reimbursement, ahead of CMS. And that often happens, that CMS will start a movement towards something. I'm thinking about, for example, prospective payment bundles. And then we see adoption by some commercial payers that leapfrogs where CMS is and or pulls back, as happened with some of those bundles. So this is a pattern that's common. Now, we're getting a number of questions around that I'll bring together, and it's around the theme of models where it's not the physicians doing the monitoring, running the monitoring, engaging the monitoring, but either the payer themselves or an employer maybe is looking to get devices or license directly for devices and put them to work, or where a outsource model, a turnkey outsource model is being employed, where again, typically it's going to be the payer, maybe in some instances a provider, is not affecting the provider's workflow, but is externalizing the job of remote monitoring. Do we feel like the reimbursement for those models is ready to go, or is that an area that we as an industry still need to figure out?
I have a pretty strong perspective on this.
Well, go ahead then, please.
Start. So as an organization, we really believe in the outsourced or clinical services model. We have seen time and time again that even, the best resourced and best intentioned hospitals, health systems, practices, do not necessarily have the bandwidth to stand up these programs themselves. I think that's only been exacerbated in the last 18 months as resources have been diverted to deal with the pandemic. We're dealing with provider shortages, nursing shortages, et cetera. And so increasingly, I think this is going to become more and more important to how folks implement. The reason I said I have a strong perspective on this is because as an organization, we've always taken a provider to patient approach. So everything that we do digitally, clinically, et cetera, is on behalf of the provider. We believe that that's the strongest relationship in healthcare, the place where there's the greatest trust. There was a Sony survey a couple of years ago that basically said more than 50% of patients would actually switch doctors if they would do remote patient monitoring. And so, I think that's a testament to really how strong and foundational that relationship is.
Tommy, let me go direct and ask you, do you think the reimbursement model for outsource works the way that we think over time the reimbursement model for the physicians to do this is working?
So it's the same model ultimately, and it's
right. But the question is
how we divide the pie, right? So ultimately, I think there are different kind of risks that we have to manage on both sides. When it's the physician deploying it and taking, let's say 100% of the pie, or probably less because they typically work with a company for device provisioning, et cetera. The workflow challenges are real, and they may not be maximizing despite doing, all of the really important work of patient management. On the other side, the reimbursement, it's very tough to get the unit economics to work when you are working with a partner of, well, what cut is the physician's, what cut goes to your vendor and the clinical services that have a very real cost associated with them. And that's why I think this kind of interesting intersection of both fee for service and value-based is so important. It's not impossible. We and many others are doing it in this space, but I think we will need to see some changes to what shape and form this takes, and also look at models that really reward the clinical outcomes that are generated.
Before we go to my next general question, before I do that, anybody else want to address that question about whether the current reimbursement is going to work for both physician-led and physician outsourced, and whoever outsourced? Any other comments on that question?
I think just one example that comes to mind to me that's slightly different, but worth putting out. For example, there's a company called AliveCore as of today that has designed this consumer device that allows to screen for arrhythmia. So any patients or any consumer can buy that, and if they feel that they have palpitation, etc., they can record their ECG, that sends that to a doctor that will analyze it for them. That kind of remote patient monitoring is entirely paid by the patient out of pockets. They have to buy the device, they have to pay the subscription to get access to the doctor. So it's sort of an outsourced model, but owned by the patient, and there's no coverage for that whatsoever for the patient typically.
Right, and so benefit design may be actually one of the areas that we need to be talking about, not just straight provider reimbursement. That's a great point, Aurelie. And I want to come back to the patient model if we have time before we run out, or the patient role if we have time before we come out, because we did get asked a question about that. But so far, this conversation has been predominantly US-centric. We have attendees coming in from all over the world, some of which are looking to do business in the US market. But, there's been obvious investments in other countries, UAE. I think NHS in the UK has been struggling to figure out how to handle this and where it fits into their models. What experiences do any of y'all have about the way reimbursement for patient monitoring is being done outside the US that the audience might want to hear?
I can speak for France. Typically, that's a market that we know pretty well at Cardiologs, since that's the home country of the company. But typically, I mean, for France and Europe in general, I think everybody knows here how fragmented this market is when it comes to Europe. So reimbursement for RPM will take, very different shapes and forms across the different countries. But for France, so it's a public healthcare system, right? There's national coverage for all. And they're very much experimenting with RPM as of today. And before making a decision that will impact the entire healthcare system. Right now, they're running a 4-year-long pilot program called ETAP to evaluate the reimbursement of RPM in 5 specific indications that they have chosen. So I think there's heart failure, kidney failure, respiratory failure, diabetes, and implantable cardiac monitors. And by the end, actually, the 4 years are coming to an end. So by the end of 2021, we should have a clearer picture of what RPM reimbursement in France could look like. But I can tell you something, it's already going to be much less money than it is in the US. I think right now we're talking about maybe a couple $100 per patient per year for that entire monitoring. So it will come, but yeah, there will be less money in Europe and in France in particular.
Yeah,
Any other comments on the international market? Go ahead, Julie.
Yeah, I was going to say, I mean, I think what Arlie mentioned is the per patient per year is an interesting factor. And that's the question that we always get when we're working with European partners and clients. Obviously, it's a totally different payment system. The closest to the US, you could argue, is Germany, but even that, it's still light years away from the way that we're structured here. I think what we hear a lot is that price per patient. That's definitely a business model that is looked at. I think also there's a lot more of an interest in privacy, especially in the European nations, and also many parts of Asia. So, if you think about what RPM is doing in a lot of cases, there is that data feed that is somewhat real time. And that has been where there's been a bit of skepticism. At the same time, I think now that the algorithms are getting more advanced, there's the market shift because of the COVID-19 pandemic has just shifted the expectations and the needs. And then I think just the last piece, again, just going back to that price or cost per patient. I think to Arlie's mention, there's a little less overhead. And so when we think outside of the US, and so when we get into those, again, those outcomes metrics, and we look at the actual, the value that is being driven, that's huge. I think the secondary piece is that a lot of nations are looking at mental health with RPM, where maybe there's a little bit more resistance to the wearables and that sharing of data. But something like questionnaires or ways to check in on a patient remotely, or I should say healthcare consumer in that regard, that's definitely peaked, especially the last 18 months.
Very good. I want to bring it back then to the patient. We've got about 10 minutes left. We're getting a lot of good questions. We won't get to all of them. I'd invite the panelists, any you don't feel like we've addressed, to go ahead and answer things in the chat before we run out of time. But the question I want to pose to everybody is around the role of the patient, right? I mean, we say reimbursement, we typically think it's the insurance company or the government paying a provider, paying a RPM company. It's a provider paying an RPM company. But none of this works if we don't have patient engagement. None of this works if we don't have participation from the patient. And as one of you just suggested, we may even look to the patient for reimbursement. And I think that's true broadly for RPM. I think it's true when we start thinking about things like remote diagnostics. I mean, the COVID test at home, I think, is a great example. I mean, as far as I know, no insurance company is reimbursing for that. But how many has Abbott sold? I mean, the point I'm making is, what do we think the role for the patient is? Should the patient be involved? Should there be financial incentives from the, if we want to have RPM being used? Should it be something that's addressed in benefit design? Is it something where it's just a separate marketing opportunity? I mean, Fitbit doesn't sell to insurance companies or doctors. Fitbit sells to patients or healthcare consumers. So what is the role for the patient in getting involved and involved in the financing?
Tanvi, I can see you're eager. Go ahead. You go first.
It's super interesting because when we first started Beta Health, it was really founded on this principle that patients deserve more than what our healthcare experiences are giving them. And really looking at how do we bring patients into the fold of their health management in a deeper and more sustainable way. And remote patient monitoring was kind of top of mind for us at that time, particularly in the realm of IoT being a big thing. What we learned very quickly is that the patients who require these types of interventions often are not necessarily the ones that are buying a device from Fitbit or Omron or any of these kind of Bluetooth manufacturers, and that they still think of their healthcare in a different way than they think about their consumer experiences. And so while we try and design a consumer experience for healthcare, we really firmly believe it needs to be nestled into an existing patient and clinician workflow. But that's not to say that everything they experience thereafter doesn't meet the same user experience that they would get from any other industry, the same ease of use and things like that. And so, at Beta Health, it's partially about remote patient monitoring and devices, but it's also about the digital care pathway and personalizing that to the patient based on clinical metrics, data that we're both passively and actively gathering, understanding what is date of diagnosis, is this patient a smoker, what are their true motivators, is this person engaging in a program like this because they want to be able to attend their grandchild's wedding, or they really looking to be able to walk around the block and being able to really meet the patients at what their state and their goals are in terms of educational content, context, and support. We do this now primarily through cellular enabled devices because we have seen a very, very broad spectrum of tech access and literacy. We think nowadays everybody has a smartphone, and often the statistics support that. But the reality is some people still don't even have a cell phone, or they don't have broadband, as Julie said before, Wi-Fi in their homes. They may have a smartphone that somebody purchased for them, but they're not able to download an app. And so it's really looking at how you drive a better consumer experience in healthcare, but taking into account some of these constraints that are very real and will be, in our view, at least for the next 5 to 10 years. We're seeing this kind of converge in health and wellness more, but I don't believe we're quite there yet.
Well, and again, it's an intersection between policy and the vendors. I mean, state of California, for example, is aggressively taking federal dollars to try to bring access to certain geographies, and it's healthcare is their reason for doing so, not education. Go ahead, Julie. I think you were going to say something.
No, I was just going to say, I love how Tom, you phrased that up. I think you can't decouple technology and engagement. Those things cannot be separated, right? Because you have to build trust. I don't know if it was Arlie or Tom, you mentioned earlier, there's a shortage of workforce. So what are we going to use technology for to really augment some of that shortage where there can be a lighter touch? And I think that also comes back to segmenting population needs. I think about myself and probably a number of other folks that are commercially insured, the rise of high deductible health plans, and taking an interest in your health. But again, to do that, what is that engagement nudge? Because I look at myself, I don't see myself as a patient. I'm thankfully very well and healthy. So I'm a healthcare consumer. However, I am purchasing or engaging with health technologies daily, hourly, minute by minute. And so how do we drive that engagement, but also how do we build that trust? And so that's why I think there's definitely the piece of RPM, which is, the wearables and the technology that are critical, especially when we're getting into things like cardiovascular health, which I think all three of us care about deeply. But in addition to that, there's the engagement and the questions and how do you build that trust with patients and healthcare consumers alike. And then I think the last piece that I'm excited about and very curious to see what the federal government here in the United States does, which is the MCIT, medical coverage for innovative technology, and if that will continue, because it allows not only innovation to come to market faster, but it also gives view to a patients and for companies, small and large, to test things out and see what patients and healthcare consumers want, what's sticking. And I think that innovation is needed in this space, and to start thinking about what healthcare consumers want in their health journey.
So as we wrap up our time together, I want to give each of you guys one more minute to kind of bring any closing thoughts you have, topics that we didn't address you feel like we should, or a comment around some of the questions you didn't get a chance to speak to. And Arlie, you haven't spoken. You're the one who has spoken least. It's been the longest since you had a chance to speak. So let me let you start, please. In a minute, what do you want to leave our audience with in terms of thoughts on this reimbursement topic?
Sure. No, to be honest, there's one last comment that I guess I want to make on that patient piece. We shouldn't forget that if they're engaged, they're going to have a copay, and that may seem like something that's relatively small, since I don't know, physicians can make $100 per month, so maybe like $20 or $30, but that's not negligible, and so there needs to be a positive feedback loop for them to stay engaged, to continue. Otherwise, you lose the value for everybody. So as we design technologies, and that's our role in the industry, to create tools that we enable to have that feedback loop in between the physician and the patient, so that they really do feel like they have the physician in their pocket, basically. And so there's a reason why they're paying for that. So I think that's just something that we have to keep in mind as we think of reimbursement, is also the impact on the patient and their copay and how they're going to handle that.
That's great. That's great. Julie, you want to go next?
Yeah, I mean, I think this has been a great discussion. So thank you for the questions in the chat and the panelists. I think most things have been said. I would just think I love the question at the end that you asked, Jay, around the patient. I think building infrastructure and all the things that Tanvi mentioned around, giving the tools to the patient and healthcare consumer populations around the world that are going to make, number one, things equitable. Number two, it not feel so daunting. And then I think RPM is a great on-road to the health system, instead of going from feeling healthy to an emergency room. So I'm very eager to see the innovation that's going to happen, and then the reimbursement that should go in parallel.
So Tanvi, we're going to give you the last word.
Thank you. No, just echo what everybody said. It's just been a really fun discussion, and something I think we're all passionate about. It's evolving so quickly, and I think it's super important we continue to really keep the patient at the center of this. And reimbursement is not here for reimbursement's sake. It's really looking at how do we ultimately impact patient lives and generate better patient outcomes. And my hope is that any continued innovation in this space and continued changes to the reimbursement landscape do keep that front and center. There's one question from Jake Bramwell that I thought was a good one. Yes, in theory, it is possible for vendors to bill directly. It's actually something that we're doing, but in partnership with health systems. I think more will continue to evolve in this space, but lots of different innovative approaches, and it's always fun to see everyone's takes on this. So thank you.
Yeah, Jake's question, which I hadn't ignored, I was actually going to hit it in my summary, is really, well, can't organizations like some of the panelists companies here simply provide the services and bill for them directly and kind of, drop some of that proceeds into the provider's lap for the steerage that they would provide? And it's exactly those kind of concerns, I think, is at the heart. When I talk to insurance executives and people who design benefit programs and physician reimbursement, they're not questioning whether RPM is a good idea. They're questioning, how do we prevent abuses of RPM? How do we make sure that if we're not just writing checks to people and not seeing value? So as this progresses, the key thing, I think, for everybody involved, whether it's vendors, providers, advocates for patients, is focusing on where the value in RPM is bringing value to the system and finding ways that we can finance and incentivize those things while properly correcting and walling off the misuse of the same codes and the same reimbursement methods in ways that are not adding value. So what I leave everybody with as we run out of time is the story of patient monitoring and reimbursement is all about value. If there's value to the system will pay for it. With fits and starts and missed publications by CMS and everything notwithstanding, the system will pay for it if there's value. What we have to do as an industry is make sure we're articulating that value really well. And I think the information brought forward by our panelists today is a great kind of statement of where we are with that. On behalf of MedCity News, I just want to thank all of you for being here. We really appreciate your time and your participation, and back to you.
Thank you so much, Jay, and to all the panelists. I'm going to ask your indulgence and have you guys address a question from the chat that I think helps us as journalists. There's a question from Paul that suggests, are you able to provide some examples of providers who are embracing RPM? In other words, can you name some health systems that are perhaps further ahead in embracing than some others?
Right, and one of the, I mentioned a couple that I happen to know about: Kaiser Permanente, Accenture. Accenture, listen to me. Kaiser Permanente, Jefferson Health, and Ascension were three that I've listed. There's others that were mentioned in categorical terms, but again, those are just three of many, and I don't mean to leave anybody out unintentionally or suggest that there's not others that are further along. What they all have in common, and I think this is the key thing, is that they have meaningful financial incentives for outcomes. And to me, that is going to be necessary for us to see more provider investment in this outside of a payer reimbursement. Is the payers are reimbursing, you're just reimbursing through outcomes rather than total cost of care measures, ER avoidance measures, those kind of things, as opposed to paying the third fee for service.
Thanks, Jay. Anyone else on the panel want to name some other folks?
I would say that the waiver, and then we know, obviously clients like Hopkins, Dartmouth Hitchcock, and a number of others are well down this path.
Aurelie, Tanvi?
Nobody specifically, but as I mentioned earlier, we're seeing it with clinically integrated networks, folks, again, that we've seen do a lot of consolidation in the last years around the ambulatory care model. So these are the types of people.
Great. This was really truly a fascinating discussion. I know very little about reimbursement, so I took a lot away from this discussion. Again, thank you to Jay, Julie, Aurelie, Tanvi for a fabulous discussion.